Good morning. Welcome again back to the third panel in our keynote symposium on the application context, understanding how modeling can be used to evaluate priorities for evaluating treatments and vaccination. And the format of this panel will be similar to the previous two. We'll have lightning round presentations from the three modeling teams, followed by an open Q&A panel discussion. So I will start by first introducing Beata Jan from UMIT, University of Health Sciences, Medical Informatics and Technology in Austria, to present a brief overview of her team's work. Beata.
Thank you, Lisa. So targeted COVID-19 vaccination strategies and agent-based modeling evaluation considering limited vaccination capacities. My name is Beata Jan. I'm an assistant professor at UMIT University for Health Science in Austria. And together with Uwe Siebert, the head of our department, I'm leading this project. Today, later on also with us, Martin Biecher, our head programmer of the Austrian population model from the Technical University of Vienna and WHO. Before I start, I would like to thank our entire research team for their continuous support. And I would like to thank all the people supporting the entire SMDM COVID-19 modeling initiatives, the Gordon and Betty Moore Foundation, and the organizers of this exciting event today. At the beginning of the project, we set up a standing policy and expert panel consisting of leading decision makers of the field and with experts in medical field, vaccinology and virology, and international modelers. We are proud that investigators of our team and the expert panel serve in the Austrian COVID Task Force and Prognosis Consortium. Next slide, please. More than 100 vaccine candidates are currently being tested. And according to the WHO landscape, 10 vaccines are in phase 3, the last phase in the development of a vaccine before it gets through licensure. Already now, there is a big debate on how to allocate limited number of vaccines that will be available at the beginning. In Europe, they have been developed vaccination strategies, and in Austria, it is assumed that 300 individuals out of 8 million inhabitants could be vaccinated at the beginning. So the aim of our project is to inform decision makers now at an early stage on the optimal distribution of health and non-health outcomes of targeted COVID-19 vaccination strategies, accounting for limited vaccination capacities and adherence to support vaccination prioritization in combination with further containment measures in Austria. The results of our project will support setting up vaccination programs, including information campaigns and to install vaccination sites ahead. We also aim to support international modeling teams and decision makers. In our analysis, next slide, we apply a recently published agent-based population model that reflects the comprehensive networking structure and regionality. We consider a hypothetical wave of infections in Austria, including previous successful non-pharmacological interventions. The model has been calibrated and a starting scenario similar to August 2020 was defined. We are developing a forward selection optimization approach to distribute batches of vaccines stepwise to different subgroups. Next slide, please. Important for our simulation is, first of all, to understand the impact of vaccines. And here we learn from our biologists of the panel that the vaccine may not necessarily provide sterilizing immunity. In fact, it may not necessarily prevent acquiring the virus, but most likely, in their opinion, it will prevent disease or symptoms and complications from the virus. Second, the characteristics of the vaccines impacts the selection of the target population, but also acceptance and outcomes of vaccination strategies. But what are relevant outcomes? The selection of relevant outcomes is advised in the project by decision makers who need to maximize benefits, minimize harm, preserve healthcare and social and economic system. In a recent article from the Fred Hutchinson Cancer Center, it was shown that allocation strategies are different depending on selected outcomes. Currently, in our model, we focus on mortality as the main outcome parameter, but the model also reports on incidence and severity, as well as hospital and ICU capacity, and people that are quarantined, for example. Our considered target populations include age groups, healthcare workers, and people at risk. Current challenges: we are working on the definition of parameters characterizing the vaccine and its effectiveness, the implementation of healthcare workers, and for the starting scenario, we decided to use a stable situation, but unfortunately, currently here in Austria, we see an upswing. For more detailed information also on the model, please join us later on in the meeting the grantee session. Thank you.
Terrific. Thank you so much, Beata. We'll look forward to learning more details in the Q&A. Next, I'll turn it over to Sean Liu from College of Engineering at the University of Washington for a brief overview of their model.
Thank you so much, Lisa, and good morning. I'm Sean Liu, an Associate Professor of Industrial and Systems Engineering at the University of Washington. I'm presenting our research on optimizing societal reopening plans and vaccine distribution strategies under COVID-19 using simulation optimization tools. Our UW team members include Saren Lee and Professor Zelda Zabinski from Engineering, Professor Judy Weiserheit and Jennifer Ross from Schools of Medicine and Global Health, and Professor Shi Chen from the Foster School of Business. Next slide, please. Policymakers continue to have uncertainties on how to answer important questions about the novel coronavirus, such as when and how to keep society open and how to distribute a vaccine in the near future. Our research estimates the impact of non-pharmaceutical interventions, vaccination, and health systems response on COVID-19 transmission. We solve for the optimal strategies to control outbreaks in an urban setting. There are two primary aims. In the first aim, we have developed a calibrated agent-based simulation model for a large city use case, for example, the Greater Seattle, to project COVID-19 outbreaks without available vaccines through the spring of 2021. In the second aim, once safe and effective vaccines become available, we plan to optimize vaccine rollout programs in combinations of NPIs for a large city to remain open and target COVID-19 elimination in the next 3 years. Key features of this research include developing a model that uses local data to generate policy recommendations to lower COVID-19 infections. The agent-based simulation model is flexible to generate multiple projections based on possible combinations of public health interventions with uncertainty. Second, our model adds the decision-making capability from the operations research perspective. We will address the dynamic nature of the vaccine rollout programs as the production capacity, uptake, and allocation priority keep evolving in the next several years. Next slide, please. Now let's take a look at the modeling framework. We modified the open source Fred model to create an agent-based simulation of COVID-19 transmission. There are 4 components. First, model inputs include population demographics and contact networks that were generated from US Census data, as well as epidemic and disease-specific parameters. We calibrated regional COVID-19 transmissibility, contact patterns, and home quarantine compliance to target the basic reproduction number are not, as well as infection fatality ratio. Second, the natural history of COVID-19 follows a modified susceptible, exposed, infectious, and recovered structure, also known as the SCIR model. For each day, individuals could interact with other individuals in their household, neighborhood, workplace, and school. When susceptible individuals are exposed, they may become infectious after a latent period. Depending on their age, individuals may become symptomatic with various severities. Third, we include interventions such as social distancing, face mask use, school reopening, home quarantine, testing, contact tracing, and vaccines when that becomes available. We have full flexibility to simulate degrees of openness in various locations, compliance to interventions, and service capacities. Lastly, main model outcomes include population health outcomes and health service resource use. Next slide, please. We have some preliminary results from AIM-1, which is the case without vaccine. We found that certain combinations of social distancing and face mask use can contain COVID-19. Safe reopening of school really depends on at least 75% of face mask use in the community. We also recommend sufficient levels of testing and contact tracing with other combinations of NPIs. We hope these findings can provide actionable insights on the best interventions to save lives and minimize social disruptions. Thank you very much, and I look forward to seeing some of you in the breakout room.
Terrific. Thank you so much, Sean, for those very provocative results. We'll look forward to discussing those. Next, I'll turn it over to our third team, Lauren Myers and Mike Pinoni from Dell Medical School at UT Austin.
Hey, everybody. Get my video started here. Thank you so much, and thanks for the opportunity to present today. I'm very happy to present on behalf of our team at the University of Texas, Austin, on coupling COVID-19 social distancing with influenza vaccination to manage healthcare surges. And the impetus for this work really comes from the observation that while COVID-19 has had, obviously huge effects on morbidity and mortality, we've been relatively lucky that it emerged in the United States at the end of the respiratory virus season, which is typically in the winter. We've been able to get through the first wave of COVID without having to encounter high levels of other respiratory viruses. But as we move into the winter, we need to be concerned that hospitals will often experience high volumes of admissions in the winter due to respiratory viruses, including influenza. And there's a concern that the combined effects of flu and COVID could overwhelm health systems in a second or third wave of the COVID pandemic. Fortunately, we have the opportunity to influence the incidence of these two important respiratory illnesses and reduce the chance of the uncontrolled outbreak. And that's really the impetus for our work. And I want to thank SMDM and the Moore Foundation, as well as my colleagues, for the opportunity to do this work. We can go to the next slide. So the project aims for us are to extend our existing COVID-19 transmission model, which was developed originally in response to epidemic flu and then altered for COVID-19, to incorporate the expected co-circulation of influenza and COVID-19 for the respiratory virus season beginning now in the fall of 2020 and extending into the spring of 2021. And then to look at strategies that combine non-pharmacologic interventions like social distancing with influenza vaccination levels and antiviral treatments to reduce the transmission of flu and COVID, and therefore the healthcare demands of COVID-19 and influenza on the healthcare system. Now, specifically, we're going to look at a range of effectiveness of non-pharmacologic interventions, simulating what might happen with stringent, moderate, or relatively lax adherence to non-pharmacologic interventions. And then we'll look at different levels of influenza vaccination and coverage, as well as the unknown of influenza vaccine efficacy, and then look at those effects on the incidence of disease, both diseases, hospitalizations, ICU utilization, ventilator utilization, and mortality during the the 2020-2021 season. And we're going to do this work in our Austin metropolitan area, which has a population of about 2.2 million. One of the nice features of our modeling work is that we've been able to bring together all of the healthcare systems in this metropolitan region so that we can get weekly data on actual incidents of hospitalizations, hospital census, ICU utilization, and ventilator utilization, so that we can be constantly recalibrating our models to reflect the realities that we're observing in the region. We've also used this regional collaboration to make more accurate estimates of actual bed capacity and how those bed capacities change over time, which is also essential for this work. Next slide. So in terms of the parameters for the model, I'm not going to go into great detail. We can talk about that more in the chat session, but we're going to compare a range of influenza vaccination coverage from 30 to 60%. Typically in the US, we get about 45% vaccination coverage. So this is looking at both lower and higher rates, and then different levels of efficacy that have been drawn from historic data on previous flu vaccinations. We'll examine different levels of NPI efficacy, ranging from an effective R as poor as 2.2 to as successful as 1.2. And again, with the following outcomes that I mentioned earlier. Next slide. And this is just a little bit of an illustration of some of the results that we'll be able to bring together. This is just a first pass at some of our simulations. You can see here that on the y-axis, we have incidence of disease, both with COVID and influenza, time since September 1st on the x-axis, and then three scenarios, the high transmission scenario, a medium transmission scenario, and a low transmission scenario. And then we'll look at those different scenarios of transmission, compare different vaccination rates, in addition to these different levels of transmission based on the non-pharmacologic interventions, not only for incidence, but for the other outcomes of interest. We also will present these results to our local healthcare system leaders in helping to plan both for vaccination efforts that are ongoing right now, and also for changes in hospital capacity, which we look at periodically here in Austin, at least monthly, if not more frequently. And that's pretty much everything I wanted to say. Lauren, anything that you wanted to add?
No, that was a great overview, but happy to answer any questions about the origins of this model and our plans for analyzing it. Nice to meet all of you.
Thank you.
Great, terrific. Thanks so much for that summary. And I'd like to invite all of our panelists from the session back onto the screen. Oh, I see everyone's here, terrific. So we're gonna open it up for Q&A, and I'm gonna start with a question about assumptions around vaccination. So each of your models incorporates a vaccination strategy, either influenza or a hypothetical COVID vaccine. And there are questions of uptake for both types of vaccines and additional questions regarding supply for COVID vaccine. But could you comment on your perspective on how personal decisions to get vaccinated will affect overall coverage rates, and how you're incorporating these assumptions into your models? And in particular, how the levels of uptake may not match recommendations for prioritization of vaccine in a limited supply scenario. Someone like to jump in?
Yeah, sure. I can take a first stab at it. This is a very interesting question about balancing supply and demand under great uncertainty. There's a very good recent National Academy report on equitable COVID-19 vaccine allocations that describe 4 phases of rollout. So initially, we have a jumpstart phase. So the vaccine supplies will be very limited, and then the rollout will be limited to a highest priority groups. And we also believe there may be really a large vaccine hesitancy during the early rollout period, so demand could be low. So I think everyone have seen some recent surveys shows only maybe a quarter to a third of participants may not take the vaccines when it first becomes available. So I think the initial set of questions will be focusing on building up the supply chain. And then after, when the vaccine is proven to be safe and effective, we believe that the demand will increase, and then the logistics will also be gradually become mature. So eventually there will be sufficient supplies. Then the question really will shift to the providing vaccine incentive to increase the uptake. So we have done some early work on flu vaccination uptake. So for that research, we take the perspective of the health insurance. So the question is how to optimize these incentives, such as providing either rebate or cash award or reducing co-insurance to increase incentives for the uptake. So the nice thing about using an agent-based simulation model is we can simulate various strategies considering different priority group and their different supply limit, as well as uptake scenarios, since we're modeling individual agent. And we hope to use these models to really project different outcomes under these assumptions.
Great, thank you. Other teams?
For our work, we're specifically looking at what happens before a COVID vaccine. So we're taking the COVID vaccination question out, but it really applies to flu vaccination as well. And while I was giving you kind of overall rates, there's definitely variation in flu vaccination rates, with the very young and the very old having higher rates of vaccination than those in the middle. Our model could, I believe, accommodate looking at differences across different age groups. It already deals with different age groups according to the risk of complications and so forth. So I think that would be another step that we could take. But I'm also cognizant of the fact that probably everybody can benefit from a flu shot in the sense of just reducing overall spread. Lauren, do you want to add anything?
We have a construction project in the background. It's very noisy, but I'll just add that right now the model, the distribution, the timeline of distribution of flu vaccines in the model is parameterized according to typical seasonal flu vaccine uptake rates across the months when people typically get vaccinated. And we just scale those to model the different levels of uptake from kind of typical to above typical to below typical to consider a scenario where people are not getting as many flu, not as likely to get flu vaccines because of lack of access to healthcare or concerns about, raise concerns about flu vaccines, or the scenario, the more optimistic scenario where the proactive efforts to get people vaccinated are actually having the desired effect. But as Mike said, we could add some age-specific details to that, but we haven't yet. And I'll just say, I'll just mention, this is not, we're not looking at COVID vaccine uptake, but the recent surveys from CNN and Pew are really kind of disturbing. We're seeing that right now they're reporting like their interest in getting COVID vaccines. They've declined from like 66% and to 56%. It's down to 51% as of this week. And the Pew study suggests that there's really concerning disparities among racial and ethnic groups, with willingness or interest in getting vaccine among Black Americans being as low as like 32%. So I think these are really important things to consider when we're modeling these out.
Thank you. Beata.
Well, for our Austrian model, our Asian-based model, we assume batches of vaccines being distributed to subpopulations stepwise. And distributing these batches, here we consider a potential maximum uptake. In Austria, most likely we will not have a compulsory vaccination. However, uptake of vaccine will strongly depend on the vaccine itself, its spectrum of side effects, and also information campaigns, and the overall situation, so how it involves and how about the numbers of infection and additional measures that we will face at this situation when the vaccine will hopefully be approved. And currently we are running a survey to define ranges of potential uptake. And here we are considering different age groups and risk groups, because it really varies upon. So for the first results that we got, I can say that, for example, for younger age groups, so kids, it's rather low, assumed to the uptake, and it's a little higher than in older age groups. But Uwe, is there anything you would like to add from your perspective?
No, I think this, maybe very briefly, this explained it. As you remember, we are looking for a priority list, who gets the first, whatever, 100,000, who gets the second, and so on. So this list will be valid even beyond the first batches. So sometime there will be the second batches and the third batches. So this could even go along a year or so. And always the second batch and the third batch, the solution is made conditional on having the optimal first one. We try to get a number for the supply. We try to get a number that is smaller than the smallest subgroup, because if a small subgroup is the preferred solution, then our number of vaccines should be smaller than that. And it's smaller than what we expect in Austria. As Bert has mentioned, the Austrian government, which is a small country, has ordered 300,000 vaccines, and so that's why we took 100,000. More difficult is the adherence thing, because it first looks like it's not a problem, because if a person doesn't want to get vaccinated, then we would use that vaccine for the next person. So it really doesn't matter whether person A is vaccinated or B, because it basically means that it goes on. Now, if the only problem could happen if we say, let's say we vaccinate all nursing homes, and we assume a 60% herd immunity would be sufficient, so that you would not spend further batches on that population, and you go to another one. And if the adherence then would be smaller than 60%, we would assume that we have vaccinated 60% of the people. That's fine. But reality would maybe only give us 40%, and then our model would be off. And that's a very interesting question. And it remains really to be seen how many people in the end want to get the early vaccination. So we don't have that problem with the first 100,000, right? Because you will always find people. But if we talk about the end of the year, 2021, we will have that problem. We probably know more by that time about adherence. So for now, it's really not a technical problem for us as we start giving priorities first. And interestingly, we were concerned that this grant may not fly, because when we wrote this, people thought, oh, wait, vaccination, that's something at the end of the next year, so it's not an urgent problem. Now we're nearly too late now. People are already discussing the strategies, and they have to set up places where they want to vaccinate. So this is an interesting change. So we were happy to get this grant.
Great. Well, thanks for those very detailed answers. It's important to hear how each of the models is addressing this question, because as especially Lauren, as you noted from the data, we see that there are potentially declining responses to uptake of vaccination, and especially important to consider how that might contribute to disparities among vaccinated and unvaccinated populations. There was a question in the Q&A that seems to have disappeared. If there's still an open question, if you could please enter that again, that would be helpful. It was from Scott LaJoy, but if it's been answered by the previous answers, that's fine to leave it as is. But another question about working with decision makers. So a key goal for this funding initiative was to support modeling teams for working directly with decision makers. And if you could comment on how this partnership is working, specific requests they've made, and any advice for others working directly with decision makers.
Sure, maybe I can go first. I think we've had a really great collaboration. Thanks a lot, in large part to Dr. Meyer's continued work to keep bringing new modeling work back to our decision makers. We've been able to get in front of decision makers on as much as a weekly basis over the summer to present the modeling results, and that's to the mayor, the county judge, who's the county official, state senator, and then all the leaders of the major healthcare systems locally. And I think it's made a huge difference in our local planning, particularly when there was real concern that we were going to overwhelm the hospitals during the summer, and when to stand up, for instance, a field hospital or things like that. I hope that we won't need that same level of scrutiny this winter, but it's absolutely possible that we could. And I at least am looking forward to getting in front of those decision makers. One of the challenges is that I think the hurricane model of disasters has dominated disaster planning here in Central Texas. So slow rolling epidemics that just get worse and worse week to week aren't as in that decision making space. and then understanding when you're reaching hospital capacity that's actually resulting in excess mortality. Many of our leaders have wanted a bright line number, and I don't think that's actually how it really plays out. And really look to Lauren Cipriano's work and others to think about how we can better model the chaos around surges so that we properly account for its degradation of care. And that's in all aspects, ICU, ventilator, floor beds, depending on the individual circumstance.
Great, thank you. Other panelists?
So our decision makers include the health officers at the Public Health Seattle, King County, and the Washington State. So earlier this year, the University of Washington Global Health sponsored a public panel on COVID-19 with these key local decision makers, as well as experts at UW. So this was hosted by Professor Judy Wasserheit on our team. So at that panel, we learned some of the key local issues and questions. So we have been in contact with Dr. Jeffrey Duchin, which is the King County Health Officer. So primarily right now is about data collection. So we are in contact to inquire local data, especially related to contact tracing capacities. So with more data coming in and more preliminary result rolling out, we plan to provide policy report, very short, very succinct, through emails, as well as meeting with them regularly to get their feedback on these policy findings.
Great, thank you, Sean. Beata?
Yes, from our side, when we were writing the grant, we were really actively approaching decision makers here at the government level, at the main health association, at HTA bodies. And we faced quite some interest in our project, and so we were able to set up our standing policy and advisory panel. And well, maybe as a little advice for people at the beginning of the project, you really need to think broadly who you want to involve, who are the stakeholders, and you have to make sure that you have a clear message and be respectful of their time. So we started our project then with a kickoff meeting where we invited all of them to bring them on the same page, and we were discussing like really the crucial things at the beginning, like defining the research question, potential strategies, and what are the relevant outcomes for them. And while the project is continuing, we are now planning the next meeting to present main assumptions and also our first results. And in between, we reach out with specific questions. And we have a final meeting then to present our results and discuss this and see how we could continue further. And with respect to linking to decision makers, here we at the Institute and myself, we build upon a link over the years. And how did we reach this? It is, first of all, by successful projects commissioned by decision-making bodies and organizations here in Austria. But it's also due to teaching or mentoring PhD students that come or that may later on go to these institutions. And also being active. So here in Austria, I run, for example, another chapter of the ISPOR where we have regular discussion series and where we try to bring together on a regular basis decision maker and academia, as well as regular meetings on HTA networks here in Austria. Uwe, anything you would like to add?
No, I think that the one thing that is not easy to do ad hoc is really make sure that there is, I'm here in Tyrol now since 20 years nearly, and 15 years. And I think what played out very well is since the beginning, we tried to collaborate in the regions and also in Austria as a whole, because it's a small country with all these agencies. and also we get a lot of work from them. But what Berthe mentioned lately is, I see which is rewarding. If we have people like PhD students, and sometimes we offer them a position afterwards at the institute, and then they get another offer from, like the government or the health authorities, now public health authorities, and they come to me and I say, well, I give you this offer, and as an institute head, I would like to hire you. I would like to advise you to be with us, and you could do a doctoral. But now I take on my hat of a mentor, right? Not just the institute head. And now you have the chance to work in the COVID time with the health authorities of the public insurance system and the public health institutions. So that the doers, we're the researchers, but they are the doers. And then I tell them, if I were you, go out 1 or 2 years and then come back and see whether you want to continue. So we have a lot of these people, and some of them did not come back. Some of them do the doctoral on the side while they are still in the work, and that's helpful. But that's something that I think I didn't plan that. That's just natural, and it's something which is very helpful.
Great, terrific. So thanks so much for those comments. Really excellent advice for researchers looking to work with decision makers. Establish an ongoing relationship, clear with your communication, be respectful of their time, and continue to keep those communication channels open. And thanks so much. So I have lots of other questions, but we've reached the end of our time for this panel. So I'll encourage everybody to come to the breakout sessions and bring your questions there. I want to thank all of the panelists for sharing your exciting work and for the robust discussion. We very much look forward to results in the coming months. At this point, I'll turn it back over to David Meltzer for some concluding remarks, and we'll see you in the breakout sessions. Thank you.